for our Crisis Jam. It will be a feature presentation from Charlotte Claiborne, who is the executive director for the Bridge Center for Hope based in Baton Rouge, Louisiana. So very excited for our jam this week. Let's go ahead and get started because I know we have a lot to cover. And just a reminder, if you miss any part of this, including that opening clip from The Greatest Showman, you can go to the 988 Learning Community and find everything there. This is a one-stop shop. It's available at talk.crisisnow.com. You can watch it on the TV. You can go directly to YouTube. You can pull out the various segments and view information there. And just in case the Crisis Jam disappeared from your calendar, make sure that you go to the link in the chat to have it added back. So sometimes these drop after about 6 months. And if you can believe it or not, we are on episode 141, which means that's been, I think, over 2-3 years. So make sure that you have that link. It's on your calendar. And again, you can go on YouTube. This is our top 5 Crisis Jam episodes with the most attendance, both live as well as on YouTube. You can see here some of these are special sessions like the youth session, the 1-year anniversary. But if we take a look at our top 10, particularly number 7 and number 8, these are more recent episodes. So lots of big topics here: EMS and 911 coordination, law enforcement coordination, LGBTQ plus populations, very weighty topics. So always helpful to go back and see and watch it from a new perspective. So with that in mind, those are some big topics, but if you have a topic, if you would like to present, feel free to let Karen know. You can either drop that in the chat or email her. She put her email in the chat because there are various lenses to all of those topics that have already happened, as well as topics that maybe we're not even thinking of that you are hearing locally in your area. So we want to make sure that we are continuing to feature unique speakers and making sure that we are addressing what you guys are hearing. So have an idea, put it in the chat, email Karen. All right, September is National Recovery Month. There's going to be a toolkit from SAMHSA just to help support individuals who may be in recovery, or if you're in recovery yourself, making sure that we are removing stigma and letting people know that recovery is real, hope is real. And Recovery Month Toolkit and Recovery Month itself coincides with the National Suicide Prevention Month. This year, one of the themes is You Matter. And so we have 988, Vibrant for sure, and others have materials around Suicide Prevention Month. And if we go through, you can see some of the marketing materials here. So again, just making sure that we are letting folks know that 988 Lifeline is here to help them no matter what their crisis may be. Okay. And so you can also do your part in sharing the word on 988, ordering from the SAMHSA store. You can choose from 326 items for free: posters, magnets, stickers. And I believe they may be in a little bit of a back order, but hopefully we'll get an update on that during the SAMHSA segment. And of course, you can get a 988 themed t-shirt here from the Crisis Jam: hats, long sleeves, short sleeves. You can order these online and the link is in the chat, or you can get one for free by participating in the hot seat. And so with that, I think we are going to turn it over. Oh, I'm sorry, before we get to the hot seat, we're going to do some news. So again, staffing shortages, no surprise to many of you on the call here today. Staffing shortages, not just at hospital systems, but within crisis services, crisis providers. So just some of the top 5 items that they've seen from this survey. And again, put in the chat if you think any of these apply to what you're seeing in your area. And then as well as addressing staffing shortages, also some news around opening career pathways for individuals with criminal justice background or who have been involved with the criminal justice system. Again, We are no place to keep folks out of the workplace, given all the staffing shortages. So really good paper from NASHBID and SMI Advisor. Make sure you check that out. And with that, we will go to the hot seat. And our hot seat participant today is Tanja Miles, who's the Community Engagement Advisor for Huntsman Mental Health Foundation, the founder of Set Free Indeed, author of From the Crack House to the White House. And fun fact, and I'm interested to know more about this, she has met 5 US presidents. Tanja, do you want to share with us which 5?
So yeah, it was both of the Bushes, President Obama, President Clinton, and President Carter, and all 5 of their wives. When President Bush opened up his library, we're in it. And so I was his special guest. So yes.
Yes, that's amazing. Well, so those news stories tie to the hot seat question today, and I think you're going to do well on this one, Tanja. The SAMHSA guidelines from 2020 on behavioral health crisis care, they encourage the integration of peer specialists at all levels of crisis care and support. But some federal and state policies exclude hiring peers that have been involved with the legal system. And those policies are a significant barrier to that vision. So the question for you, Tanja, today is building new horizons. That recent paper from NASHBID and SMI Advisor encourages a peer employment policy with a strong focus on excluding those with possession and intent history, excluding only those who have a past felony, excluding those who had violent felonies, or reviewing applicants on a case-by-case basis. Talk this out for us, Tanja.
Okay, so yeah, I think I know the answer, but do I get to phone a friend or
yes, phone a friend? I think you want to do an audience poll. You got both options available to you.
Okay, you know what? Let's do the audience poll, because you know what? There are a lot of smart people on this jam.
Yes. And hopefully for those who are fast, the paper is linked in the chat. So maybe you can control F search for that.
Come on, you guys. Don't let me down. You're brilliant. You're smart.
Oh, and if you want to phone a friend, looks like Justin actually wrote the toolkit.
Oh, yeah. So there's Justin. But you know what? No, I believe in these brilliant minds that is on this line. And so I'm going to go with D, view applicants on a case-by-case basis.
Awesome. Well, you are right. This audience is very smart. Let's see what that answer is. It's D. It's D. So tapping into a pool of workers with lived experience for serious mental illness, substance use disorder, criminal justice involvement will increase the peer support workforce and send an unwavering message that personal recovery is possible. Great job, Tanja. Do you want to kind of wrap this up for us and talk a little bit about the importance of peers?
Yeah, at the end of the day, we know that, everybody has a pass, and peers were key. We're not going anywhere. We're here to stay. When we are credentialed and trained, we can be some of the best folks that's on a treatment team, that's in an environment where we're helping people on their worst day get to their better days. And so we know that a lot of us have made a lot of mistakes, particularly when it even comes to maybe, distribution or things of that nature. But if we've served our time, if we've done everything according to the law to get our lives in order, then we should not be penalized for that. If we talk about peers using our lived experience, and most of us have that background, then we should not be punished for it or not penalized, but given the power to make that right, to make that wrong right. So hopefully someone else will not do the same things that we did. So I'm excited about this.
Well said, Tanja. And thank you, Justin, and everyone who worked on that report. Today's quote is from that report, creating exceptions despite people's background, viewing them as a whole person, that case-by-case basis, that holistic view that Tanja just mentioned. This is so important. And again, we must expand the table and not keep people out. So good quote there. Let's move on to our featured presentation, I believe. And here I will turn it over to Charlotte Claiborne of the Bridge Center for Hope.
Good morning, and thank you guys for having me. I am excited to be able to bring this opportunity to present the Bridge Center for Hope. I just want to take a moment and say, first of all, that the Greatest Showman introduction kind of tugged at my heart, so my voice is a little shaky because I felt all of that. And I also wanted to thank some of the people that are on this call, and they know who they are, but their valuable contributions have played such a pivotal role in the formation and the creation of the Bridge Center for Hope and bringing that vision to a tangible reality. So let us begin. So I titled this presentation Pioneering Crisis Services. And when we talk about pioneers, we think about people who are doing the first of something, or people who forge ahead, or people who are trying to implement something. And so the Bridge Center for Hope is that truly a pioneer of crisis services in the state of Louisiana, because we are the first and only crisis receiving center in the state. So we are bringing innovative evidence-based crisis services here to our state. And we're hoping that with our efforts, then we'll be able to duplicate this in other parts of our region. So in order, when we talk about the Bridge Center, we talk about the history. You have to know our history to be able to understand what we do. Next slide. Okay, so typically when you talk about the history, you want to talk about there are many instrumental people in the fruition of the Bridge Center for Success, many who are on this call, but the Bridge Center story is not unique. But what it is birthed out of necessity of a very long, intensive labor. So when we talk about it, we talk about how do we get started? Next slide. So in Baton Rouge, the local charity hospital, which was Earl K. Long, had a mental health emergency room extension. And that's thanks in part to Dr. Kosowski and so many others, but it was created to address the psychiatric patients that presented in the emergency rooms. And it closed in 2013 when the administration was looking for ways to save money. And then as a result of Earl K. Long's closure, a lot of people started going to the nearest hospital, which was the Baton Rouge General Mid-City campus. And it too also closed shortly thereafter in 2015 because the administration privatized university-ran hospitals that served the indigent population, and the state also rejected Medicaid expansion. Next slide. So now what? There was a dramatic increase in the number of PECs and CECs in our parish, and that is what we call our involuntary commitments. We're the only state that does a CEC, which is a coronary emergency certificate, to accompany a PEC, which is a physician emergency certificate, to hold someone in an involuntary state. We also had an increase in the number of 911 calls for psychiatric emergencies, and that's on the next slide. And as you can see, I don't have the numbers that go back to 2012 or 2013, but you can see from 2017 to all the way to 2022, how each year those numbers increased dramatically. I think the number for 2020 was because of COVID. That number was a little bit lower, but it's still nonetheless, it still was higher than 2019. And the trajectory, it continues to go upward. So what do we do? Local community leaders and advocates and officials and law enforcement agencies, they search for ways to treat the mentally ill population, address the overcrowded emergency rooms, and to keep people out of jail. And what, as a result of that, was the birth of the Bridge Center for Hope in 2016, the nonprofit aspect of it. And after conducting several studies and seeking community engagement, doing town hall meetings, trying to explain to our city what was needed, what was so desperately needed to help the mental health population, we were able to pass a tax in 2018. Now, keep in mind, we tried to do it in 2017, but that tax did not pass. And so we went back, reformalized, organized, and went back out to the community to explain again. And so therefore in 2018, with roughly about 68% of the population decided that it would tax itself to open a mental health facility that will treat individuals in a mental health or substance use crisis. And to look at that, that is huge. You can click on the slide so you can see the thing, but that's huge when you're asking people to tax themselves to help someone else. And so the reality of the Bridge Center began to take shape after that tax passage. Next slide. So with the support of our parish, our local leaders, our community advocates, and especially our service provider, RI International, the Bridge Center was officially opened on February the 11th of 2021, and it became Louisiana first and ever only crisis receiving center, still to this date. The facility is 26,000 square feet. It has 4 units that contain either 16 crisis chairs or 16 crisis beds. It is, because of our license type, because we are a receiving center, we have a higher staffing pattern, and that requires us to have a psychiatrist, addictionologist, which is a psychiatrist that with an addiction background or certificate, psychiatric nurse practitioners, registered nurses, licensed mental health professionals, licensed practical nurses, certified peer support specialists, milieu specialists, which we also call behavioral health techs. And our facility also has in-house dining, therefore it has its own kitchen staff and our administrative supports. We are open 24 hours, 7 days a week, 364 days a year. We accept voluntary and involuntary individuals 18 years and above. And we accept individuals from law enforcement and for first responders and their dedicated interest in the back door. So we don't turn anyone away. We try to make sure that we meet everyone where they are. I kind of go back to what Tanja just said. We accept people on their worst days so that we can help them start forging ahead to their better days. So when we go through the facility, next slide. Next slide. Okay, so this is our 23-hour observation unit. As you heard me mention when we said we had 16 crisis chairs, and you will see those chairs in that unit. It provides stabilization services to individuals who are in the middle of a mental health or substance use crisis. This is where everyone comes. Everyone that comes to the facility, whether they come through the front door or through the back door, they come to this entrance right here. And the typical length of stay is 23 hours or less. And individuals are monitored for optimal observation and for their acuity and safety every 15 minutes. However, if guests are unable to be stabilized within that first 23 hours, they can be transferred to our crisis stabilization unit. And in this unit, it has 16 beds, but it was 8 double occupancy rooms. And this unit provides initial detoxification as well for individuals who are dual diagnosed, as well as MAT services. So individuals who come here, they have a longer length of stay, they have a more robust schedule. If for some reason someone is not able to be stabilized, we do rely on our community partners to be able to help us whether we have to transfer those who are having a substance use disorder, we can transfer them to a 28-day residential program. If someone needs a longer length of stay between that 2 to 4 days, then we can transfer them to one of our freestanding mental health clinics or to our hospitals. But what we do here is we stabilize individuals, and we're trying to make sure that once they are discharged with a plan and they're able to start their recovery process. Also within our facility, we have a care management and a mobile response unit, and that's on the next slide. So our care management team, this is one of our wonderful providers. Her name is Shavonda on her picture. And I wanted to say her name because every time I meet someone or a family member of someone and they have something positive to say about the Bridge Center, they always mention her name. And I receive such positive response. And I think because she's the last person that's working on them, but we have a very dedicated staff, but I just kind of know her because they always mention her name. But our care management team assists guests with their linkage to outpatient services and the community resources post-discharge. And then our mobile response unit provides the crisis intervention and stabilization services within our community when appropriate, based on referrals that we receive from our managed care providers, that's our insurance providers in the state. And then also we're starting to work with 988 to receive calls from them as well. So this unit can go out into the community. This next video, a lot of people want to know, how are we doing? And if you want to click on that. So there you go. Since the facility is opened, the facility opened up until July 30th of this year, we've had 6,976 guest presentations, and we've admitted 6,638 individuals to the facility. 78% of those individuals that come to our facility come on their own or with a loved one, so they're considered direct entries. And then 22% of those individuals are escorted by first responders or law enforcement. And when I say that, I only mean East Baton Rouge Parish, not the other surrounding areas. So that's 22% is strictly from our parish. 68% of those individuals that have come through our facility are being treated for mental health services. And then 31% is our co-occurring or our dual diagnosed individuals in our facility. And so one of the things that the Bridge Center does when we're out speaking to the public, when we're engaging in our community activities and our outreach programs, we want to make sure everyone understands the services that we provide. So we're out there in the public, we're partnering with other providers just so that they'll know and have a heightened sense of awareness. And the next slide is going to show a commercial that is currently being aired in Baton Rouge.
The Bridge Center for Hope is Baton Rouge's mental health and substance use crisis stabilization center. Since opening our doors in 2021, we've helped thousands of people receive the quality crisis care they deserve. The Bridge Center for Hope is here for you anytime, day or night, delivering hope, help, and healing. We are always open and always here. To learn more about the Bridge Center for Hope, please visit brbridge.org.
So our tagline that we tell everybody is that we're always open and we're always here, because we get so many people that don't know where they need to turn. They're not sure where they need to go. A lot of people do not want to go to the hospital. Some people are afraid to go to the hospital. So we tell them it doesn't matter. We have no respect of person. Our only criteria is that you have to be 18 years and above to utilize this service. And so the more that we normalize having help and normalizing that it shouldn't be a stigma surrounded by mental health services, the more we start seeing more and more people engage and utilize their services. So any questions? I did that kind of fast. I knew I had 15 minutes, but I wasn't sure how long I was going to talk.
Well, I think that was perfect, Charlotte. So let's bring in our roundtable to get some of their thoughts, and then we can see if there's additional questions. I know I have some items I want to talk through, but let's start with Dr. Jan Kosowski, who's the Senior VP of Behavioral Health and Human Services at Access Health Louisiana.
Okay, thank you, Charlotte, and everybody for all your work on this unit. I was the Executive Director of Capital Area Human Services when the whole idea of the Crisis Center came up. And it really was an incredible emergency. It was post-Katrina. So we had been holding meetings that included a lot of stakeholders across the whole community. And one of the things that shot up as one of the biggest needs was behavioral health crises. And they increased about 30% after Katrina and never came down. And so we had some federal dollars that we were able to use to create the first stabilization unit that was at the public hospital that Charlotte mentioned. And it was really mostly law enforcement. Well, I'd say 50% law enforcement, 50% individuals came on their own or with family or friends, and it was incredibly successful. We had kind of used the tagline that it was a portal to ongoing care, because what we did was we collected a lot of statistics, and we could show that many of the people that were using the crisis center were never getting connected to a provider in the community. And so there was no way to really reach them other than when they came in for their next crisis. And, you know, that's very hard on individuals. It's hard on families. And it's also dangerous when you especially have a serious mental health problem and that you're not connected with a provider, then truly you're just getting help each time when it's acute. So our portal to ongoing care was that we said anyone that uses this unit really needs to be connected to outpatient care, whether it was the human service district or a private provider or whoever that person wanted to see. And so unfortunately, after 3 years of great success, the state decided to close the public hospital, and that was the end of the unit. And then what we saw was a lot of our patients at the human service district were nowhere to be found. And Tanja actually introduced me to the wonderful warden at the local prison, and we started providing mental health services inside of the prison. But what was more important than that, we were able to document that these are people that really should never have ended up in jail, but they needed to get treatment. And we all know that emergency departments, that's wonderful for a medical emergency where people can stabilize you right there. But when you have a behavioral health crisis, you're not going to be treated in an emergency department. You're basically boarded there until they can find a bed. And so we decided we would try again to redevelop an updated version of the unit that we had at Earl K. Long. And we convened all of the stakeholders originally that had developed what was at Earl K. Long that worked so well. And we updated it so that we included some other attributes that we knew would be really important. And that was adding a mobile unit, as well as adding care managers, so that anyone that came into the Bridge Center would be connected for a period of time with someone that could assist them with getting appointments. So again, they could be connected to ongoing care. And I think that's really the most important thing that we can do is we don't want to just assist people in a crisis. A crisis is a wonderful time to connect people to what they need to avoid the next crisis. And I'm just very proud of what the Bridge Center has done and what the folks that work there have done. The numbers speak for themselves. It's providing a critical need in that community. It's doing exactly what it was designed to do with a lot of dignity and a lot of heart. And
Thank you, Doctor.
I'm not surprised that the people who are involved with it now are making it work so well. Thanks.
Thank you. And that you touch on, it's such a common problem. So glad to see what Louisiana is doing. You mentioned Tanja. I'm going to bring her back in. Tanja, can you share a little bit of your perspective?
Yeah, so I think y'all, you can't make this up, that you guys are talking about peers and you're talking about backgrounds and lived experience. And I remember in 2014 when Dr. Jan first approached me and said, I need some help. I don't know where my clients are. And I'm like, I know where your clients are. I see them every week because we do work inside a parish prison. And to connect her with the warden and then to call other people like law enforcement, the mayor's office, and other stakeholders and say, look, we have to do this. And Dr. Jan took us through what we needed to do when we went to different places and spaces and saw what was being done because we wanted to bring it back here. And we did that. That was a peer speaking to power who listened. And now we see the result of that. This is what we're talking about when we even started this conversation. And now to see something that was just me and her in a room talking, to see what it is now. And I remember, our first board meeting. I remember when we bust our butt to try to pass tax and went out in the community. And so now people came and they said, we need this. We've never heard of it before, but we need this. And we love the Crisis Now model because, we treat people with respect and dignity and call them guests. And so when, we were able to make that happen, we were all excited. And then I remember the day when we voted to bring Charlotte on, one of the best decisions we ever made. And now look at it now. And so when it's all said and done, it was all of us working together. It was, bringing that lived experience, bringing power and bringing people like Dr. Jan and everybody else who said we needed to do this. Right now we have a decrease in opioid deaths. And a lot of that contributes to the Bridge Center. A lot of successes that you're seeing in East Baton Rouge Parish is contributed to the Bridge Center because we have a place 24 hours, 7 days a week. We can bring people with all their scars, all their baggage, again, to get them to better days. And it's not just a building, it's a place where people can get hope, help, and healing. And so I'm grateful. And we need more like this. And now I'm grateful that I'll be working with the Huntsman Foundation to build what we think will be the biggest stabilization center in the country. We already broke ground on it. And so, again, at the end of the day, this is what team works look like.
Yeah. Well, thank you, Tanja. Always love hearing your perspective from the peer lens. I'm going to also bring in Greg DeCherry, who's the Director of Youth Empowerment at Magellan Health Services. Greg, can you tell us a little bit from where you're sitting?
Sure, certainly. Well, first off, I'm no longer the Director of Youth Empowerment at Magellan. I served there for about 14 years working with young people with mental health issues, substance use issues around youth empowerment. Now I do a little bit of consulting as well as make documentaries focused on mental health things. As a shameless plug, I have a documentary, My Ascension, is launching on PBS next month for a Suicide Prevention Month. But my history, one, I'm on the board of honored to be on the board of the Bridge Center. I took Tanja's position there as the representative with lived experience. I come to this work through peer support. I went through a peer support training in Arizona back in 2004. So next year will be my 20th anniversary of graduating from peer support training. Also go way back with RI, way back before they were even RI. They were Meta Services. I think Facebook stole the old name maybe, but I was real, when I came back to Louisiana, where I'm from here, about 7 years ago, and they had been talking about doing this center, and Louisiana can be a little backwards in some areas, shall we say, and not very innovative a lot of times. But when I heard RI was coming in to run this, center and create this center, I was really excited about that because I was very familiar with them in Arizona. I had actually worked with Mr. Covington and Paul back 10, 12 years ago at Magellan, Arizona. And, I'm also a person who's been to a lot of these kind of places. I had had about 15 different hospitalizations, which were all me being petitioned, not being able to take care of my mental health issues, substance use issues, and was in a number of these in Arizona, and it was not the greatest experience. I went in there from being manic, going in there, and it's basically like a small room that had a bunch of recliners in with just a super stressful environment. I went from being a little bit manic to literally being homicidal and wanting to break out of there. It just wasn't a good place to put someone who's having significant mental health issues. Thankfully, I've never been a patient at the Bridge Center, but I have got to tour it and really see the real welcoming environment, the kind of place that it is. You can feel hopeful, and you don't feel like you're being held captive. And a lot of the places I've seen, it's more of that. You kind of feel like you're in jail, which when you're having a mental health crisis can be extremely, problematic and just really escalate things. So I'm very grateful that I get to again sit on the board and grateful to, be here and be well, thanks to a lot of the different services that I've received over the years and got to be a part of. Also, I see Terrence Smithers on here. I want to give him a shout out because he was there at Meta when I was working at a company, Triple R, back almost 20 years ago. So it's just great to see a lot of these people that have really committed their life to doing this work. So thank you for having me on, and thanks for letting me talk a little bit.
Yeah, well, thank you, Greg, and thank you to all of our roundtable. I'm going to bring Charlotte back to the conversation just because there are some questions in the chat and we have a little bit of time. Charlotte, I'm hoping you can tell us a little bit about how the Bridge Center helps populations that are may have intellectual or developmental disabilities who may be unhoused. Can you tell us a little bit about how you all help folks who are at extra risk or face extra discrimination?
So when you come to the Bridge Center, that's one of those things that we don't gauge or judge you on anything. We treat everybody who comes in the front door, or if they're escorted by first responders, the exact same. And that includes the housed and the unhoused. Unfortunately, here, like in so many other cities, that housing is an issue. That's just something we just cannot get around. But our dedicated care management team really works hard to try to find housing or placement for these individuals. Before you're discharged, they work closely with that person to figure out what's the best course of action. So it's on a case-by-case basis, and it depends on that individual. I did see somebody ask in the chat, what is our population, our homeless population? And I was explaining to them that in 2021, about 7% of the individuals that came in were unhoused, and about 9% for 2022. But again, that number could be skewed because we are down the street from from one of our major homeless shelters.
Dr. Jan, you had a question?
Yeah, I
comment?
just wanted to add a point based on the last question, and that is the one component that we had designed for the Bridge Center was short-term housing. That it was supposed to be for about 3 weeks after they had resolved the crisis at the center, because we knew so many people had unstable situations, and it would give the case managers time to work something out, because we all know that if you don't have a stable or a safe place to live, it's very hard to keep yourself in a good place and to be stable and safe. So if I had one thing to do, I would add that It's really critical for anyone that's doing crisis work that you don't put people out into a position that they're not going to be able to stay stable.
Yeah, that's such a good point, because we don't want folks to go from crisis to crisis. Greg, if I could ask you a question, just given the history that you've shared, can you tell us a little bit of your thoughts related to the trivia question and some of the earlier news around the staffing shortages and ensuring that there's opportunities for people who have been involved with the justice system?
Yeah, sure. I mean, I think they're starting to do more of that nationally, a lot of just separate programs through Department of Corrections and that sort of thing. I've been actually researching quite a bit as far as they have what's called reentry peer support, or sometimes it'll called criminal justice peer support, things like that, which is, I mean, back a number of years ago, and even still now, to try to get a law enforcement institution or a sheriff's department to allow someone to work within the jails, or even with people who've been probation or parole, that has that lived experience with justice involvement, is really, really difficult. But I think with some of the programs they have out there nationally, it's kind of opening the doors for more things and more work to be done, because we know peer support works, and not only does it work for the individual who's delivering or for the individual getting the peer support, but it's really transformative for the person who's getting to be that peer support specialist and help somebody else. So we know it works, and I think, hopefully not just within mental health, where in substance use we're able to grow peer support, but also within the justice system.
Awesome. Well, thank you all for this conversation. Thank you to the roundtable. Thank you, Charlotte, for telling us more about the Bridge Center. Thank you to the staff of the Bridge Center for all the work that you all do. With that, let's talk a little bit about some SAMHSA updates. Dr. Palmieri, are you with us?
I am. Thanks. Hi, Laura. Good to see you. So a couple of things I wanted to provide a few updates on. One is related to our FY23 award cycle. So we are in the process of finalizing our awards for 3 of our grant programs, including the 988 state and territory grants, the tribal tribal organization grant program, and the crisis center follow-up grant program. So those are programs where we have been able to obtain funding for FY23, and expect that those awards will be going out within the next month or so, prior to the end of fiscal year 23. So more to come on that, but very excited that we're getting close to being able to actually issue the awards for those programs and get resources into the community to support 988 response. Also wanted to flag that our July data, everyone I think knows that we have been keeping our website updated month to month with performance data for the network. And so we were able to just update with Vibrant assistance, the July data. And the July data sort of speaks to the national performance with respect to calls, chats, and texts, routed, answered, average speed to answer, and so forth. I think these are things that many of you are already familiar with. The data now does include the LGBTQI+ subnetwork, as well as our Spanish subnetwork across calls, chats, and texts, which obviously is fairly new, particularly the Spanish chat and text only since July. Also wanted to let folks know that we are on track, working closely with Vibrant as the Lifeline administrator to activate the video phone services. We've talked a lot about that being a goal for FY23, and that is on target for launch in September. So actually very soon. I did also want to point out, and I think probably Richard mentioned this, I believe last week or when he was on CDC provisional data around suicide deaths for 2022, which tragically shows an increase in the number of deaths by suicide to 49,500. Which I think is obviously a painful reminder to all of us about the essential nature of the work that we're engaged in, and also kind of going a level below the number there, looking at where some of the concerning trends exist with respect to suicide risk compared to the year prior. And for those of you who've analyzed that data, you can kind of see where there have been changes in very concerning directions, certainly for the over 65 age group, and then within race and ethnicity, you can see some notable changes across many populations, including people who identify as multiracial, Asian American, Pacific Islander, Native Hawaiian, as among others. And so this is all data, obviously, that we look at very closely. We use this to help inform our strategies moving forward in terms of how we're supporting those populations at higher risk of suicide. So more to come on that. And then I think you will see that there's some connection to all of this with suicide prevention activities, which obviously there'll be a lot of planning and activities implemented in September with our team going into the communities to amplify awareness of 988 and the messaging around that, and to encourage people to utilize the services that are available to them. So that's it, I think, for me, Laura. Thank you.
Thank you, John. SAMHSA is such a great partner, and obviously the federal agency where the 988 Lifeline is housed. So Vibrant is just so pleased for your leadership and continuing to make sure that we're sharing that data. And of course, if you need anything else, Vibrant is always willing to talk to folks. So with that, I'm going to turn it over to Arlene Stevenson for the NASHBID update. Arlene?
Hi, Laura. Hello, everyone. I'm here today to talk to you about parity and tell you about an opportunity that we have to submit comments. And I think this will be of great interest to you because this is an issue that has haunted us for a long time. Next slide, please. These are the three agencies in the state and federal government that are responsible for overseeing parity. And every year they issue a report to the Congress, and every year the report reports worse and worse behavior on behalf of insurance companies and employer health plans with regard to following the laws of parity. So they intend to amend those two laws there, MPIA and the Consolidated Appropriations Act, and they want your comments by October 2nd. This is probably the most significant opportunity we've had since 2013 when the last law was passed. This is just a graphic to show you that the problem is that behavioral health benefits, which are mental health and substance use benefits, are not equal to those that are offered for medical and surgical benefits under the very same policy. Next slide, please. And so what do we need parity? What we're trying to do is get coverage for behavioral health benefits that are no more stringent or restrictive than those for medical and surgical benefits covered by that same policy, and overall to improve access to services that everyone needs. Next slide, please. I want to mention there is an intersection between the federal laws and some states that have parity laws. The federal parity laws are very comprehensive, but they create a national floor of benefit protection, not a ceiling. In other words, states can create their own parity laws if they want to, but technically the federal law should be comprehensive enough. Next slide, please. There are many out-of-network inconsistencies with the in-network services. So what I'm going to do is kind of tell you what the major categories are, and then you'll see a list there of things that you might want to comment about, things that have impacted you as either an employer, a provider, or as a consumer. Things like, in this category, pre-authorization and network adequacy and network utilization have been big issues. Next slide, please. Another category are things that are treatment exclusions or requirements, things that they say, no, we're just not paying for that. And, you know, unfortunately, the policyholder has to live with it. Next slide, please. Then there are the financial requirements that we're all familiar with: deductibles, copays, co-insurance, and first fail policies, which are, you know, you have to finish 3 months of this before we'll allow you to go on to try this other thing. Next slide, please. There are problems with meaningful benefits for treatment, such things as ABA, nutrition counseling for eating disorders, and benefits for autism as well. Next slide, please. Then there's adequacy of provider networks. People aren't able to access an in-network provider. Sometimes there are problems with travel and distance, and a list of other things there that you want to take a look at, because those are things that may have impacted you and you'll want to comment on. There are too many restrictions. It can be based on ICD codes or DSM codes, can be concurrent review, it can be specific CPT codes that they don't reimburse or they don't reimburse well. So those are categories for you to look at as also. If you are commenting, and if possible, include data and examples. They are very powerful to these regulators. Look at the trends that you see, but be very specific about the problems that you see and report that. And some of those things might be, for example, percentage of claims rejected by a CPT code, or you see a trend in a particular insurer. For example, I see in the news United Healthcare all the time with problems. Next slide, please. And you can submit your comments electronically or by mail. There's the information to do so. Be sure you don't include any personally identifiable information, because they do post this on the internet and your name would go up. And remember, the comments are due by October 2nd. Thank you.
Thank you, Arlene. Very helpful information. Stephanie Hepburn, this week's crisis talk is from the Vault. Do you and Daniel Hopdy want to join us and give us an overview?
Yes, thanks, Laura. So you're right, and I'd like to re-welcome Daniel Hopdy. Daniel, can you share with us your experience during the pandemic?
Hello, everybody. My name is Daniel Hopdy. I'm a grateful person in recovery, thanks to the Bridge Center and some wonderful peers that helped me get through a tough period. During the pandemic, I was isolated. I'm a wartime vet, and I was dealing with mental health issues, and I could not find my way out. I isolated. I did the classic, textbook thing, but then it got worse, because unlike what we have today, where you could reach out to friends or family or whoever, we were in our own little bubbles. Like, some people took up bread making, some people took up hobbies. I took up self-destruction, and I couldn't find my way out. And I compared it to sitting into a beige room, just nothing. And that was the worst thing. It was just nothingness. And day by day, I felt a little bit more empty and lost, and just, it got to a funky point. And I want to say I am thankful for RSI, and especially the people and the peers at Bridge Center, because I had a rope around my neck, not literally, just figuratively, one of mental health and substance abuse. And they were the scissors that helped me cut that down. And just like true fashion name, they helped me create a bridge to a future that I never thought was possible. Isolation. Someone once told me the opposite of substance abuse and mental health abuse is connection. And that's what I truly believe that is provided by the peers, the crisis management, the stabilization centers, and the level of care. They have a superhuman power to touch people in a way that is, I can't explain it. But I know personally that when they say anytime, any day, they mean that. I've gone on 12-step calls, and it'll be 3 o'clock in the morning. And I cannot tell you the need. When someone is ready, they are ready. Whenever they need, they need. And they're always there. They are always there. It's a place where you don't feel like you're locked in this room where no one cares. They check on you, and the food's good too. So that never hurt. But when they sit you down and they do the intake, you realize automatically that it is not a typical mental health unit. I've been through the gambit of them, been to some really nice ones, been to some ones that were pretty much just a warehouse where you stacked on with 3 rickety chairs and a TV. This is a place of healing and compassion. And I owe them my life, along with so many others in our city. And I would love nothing more to see this grow and expand, and the services that be able to provide expand. People talk about the tax that came upon. Anyone that's going through there or knows what they do, say, I will gladly pay that over a sales tax or a cigarette tax. Tax me. If I know where my money's going like that, absolutely. I say that to say this. It took a lot of work on my part, but when I was ready, they were there to catch me.
Mhm. And I think that's the important part, is that there always has to be access and availability and opportunity when somebody reaches that moment. Thank you so much, Daniel, for hopping on with me.
Thank all of you for what you do.
Thank
Carpe
you.
diem.
Thank you.
Thank you, Stephanie. Thank you, Daniel. Daniel, before you go, I actually wanted to say thank you for sharing your story, and thank you, Stephanie, for pulling this from the vault, because I think this is just so timely. You talk a little bit about being a veteran, being a Black man, involved with the justice system. Can you tell us a little bit your experience in, finding support in those communities? I know there's the Veterans Crisis Line, there's the VCOs. Can you talk to us a little bit about how you were able to come through, in addition to of course, the Bridge Center work? But I just want to kind of, there's a lot that was on your shoulder. So I'm sure that first breath felt so good.
Yeah, definitely. There's a gentleman by the name of Dr. Daniel that said this great thing: if you want to go fast, go alone, but if you want to go far, go together. I wish I can credit one person with it, but it was a combination of the resources that were available to me that weren't available for a long time. The community of recovery is a very tight-knit one, and I'm seeing all these other services linked together. As far as my getting out of my incarceration, that was tough, and I had to find a tribe outside of that, in between working with Oxford mental health groups, continuing to stay in touch. I've made some friends with some of the peers that helped me through that period, and I myself became a peer because of the same sort of kindness and sharing, caring. I know that there's re-entry programs that are starting to reach out to these. People are looking toward the Council of Aging to help some of these people that might have fallen through the cracks. We have a long way to go, but just like a good quilt, it takes time. We're patching it together. I know that I definitely would love to see an expansion on the services be able to provide with the Bridge Center. I know they will. With whoever they got at the helm, they got it going on. But coming out, I felt like I didn't know where to turn. So I think that's why it's super important for whenever they have those assessments of services, I know they help people find placement. They give them a sense of hope. And if they can't do it, they will find someone that will. I have heard them make those calls for other people. Yo, we got somebody. Dan needs help. I don't know how to help him. Where can I go? And that's the most important part. No, not one of us is going to be able to make it all on our own. The self-made man and woman, that's a myth. But together we can, and we do. And it's taken a cultural shift. And I see that in between people coming out with the re-entry, working with Sober Livings and Oxford, to going up for follow-up on care. I've even seen people go as far as hey, your teeth hurt? Hey, here's a clinic that can help you. All of these things are getting meant together. And it's going to be something that takes time. But I know that with dedication and the crisis line and being able to see that metadata and find out where's the hurt, we don't want a Band-Aid, we want a stitch. So I think that all the components are there. It's just about pulling them together and figuring out our end goal is people, and not only just for them to live, but for them to thrive. And once that keeps in mind, everybody can.
Very well said, Daniel. Thank you so much. Thank you again, Stephanie. And I just want to encourage everyone, it's so helpful just to go back through some of the previous crisis jams, the crisis talk articles, and see them with fresh eyes and kind of a new perspective, particularly for me as I'm learning so much in this space. So I'm glad that we brought this one back from the vault. And again, if you need that website, it's talk.crisisnow.com. So let's keep going because we do want to go far and we need everyone with us. And I'm going to turn it over to my colleague from Vibrant, Shelly Polanco, who will walk us through some state updates, including, we've talked a lot here about attacks. So Shelly.
Thank you, Laura. I'll be pretty quick. Delaware last week, the governor signed the year 988 fee bill. So their fee is at 60 cents, which is the highest in the country right now, and is going to be the 8th state to introduce a fee bill and to actually pass and enacted. And the 60 cents does mirror their 911 fee as well. So just wanted to provide that quick update. I'm not sure if NAMI has any other updates to provide.
Hey, thanks, Shelly. It's Catherine with NAMI. Just want to point out quickly, Ohio is now light gold. They have legislation pending. It's HB 231 from Rep. Pavliga. Thanks.
Thank you, Shelly. Thank you, Catherine. Do we have any folks on from Delaware and Ohio who want to share some words with the Delaware passage that is now the 8th state with a 988 fee that has been enacted in law? Whether or not they are assessing it just yet is a different story, but anyone from those states who want to speak to what's going on, feel free to come off mute. I'll just give it 30 seconds.
Hi, this is Claire. This is Claire Wong, Associate Deputy Director of the Division of Substance Abuse and Mental Health here in Delaware. We were very excited about this new resource that will be made available to really provide a sustainability. So the HB 160 substitute number 2, as Shelly said, was signed last week by Governor Carney. It provided a few things in addition to directing the Department of Finance to have a 60 cents telecom surcharge for all the landlines and cell phones and prepaid phones. It also creates the Behavioral Health Crisis Intervention Services Fund to receive the revenue from the surcharge. And thirdly, it creates a Behavioral Health Crisis Intervention Service Board that will be co-chaired by the division directors from the Division of Substance Abuse and Mental Health, as well as the Division of Prevention and Behavioral Services at our Children's Department. And it will have, I believe, an 18-member board to be convening in the next year or so. The board is charged to create a plan and do a study and submit a report, I believe, is every 3 years or annually. But I can drop the language of the bill in the chat for everyone. But we're very excited the support from the governor and the legislation for this bill.
Great. Thank you, Claire, so much for that update. Thank you, Catherine and Shelly, and congratulations to the folks of Delaware. Very hard one. So in 2024, there's some updated events. So for folks who are aware, the International Initiative for Mental Health Leadership, they are having their meeting first time in person in a number of years. Next June is the 6th, 27th, 28th. So they typically back that up with a match. So you'll see on the 24th and 25th of June, 2024, the match is Liverpool in the United Kingdom for the Zero Suicide Summit. And then I believe this is the first time that they're having, or it's in conjunction with an event that will occur after the IIMHL Leadership Exchange, and that's the Crisis Jam in person. How fun is that? Maybe our Crisis Jam colleagues will allow us all to go to the Netherlands, but perhaps not. But that is June 29th and the 30th. So please mark your calendar for these events, and hopefully folks can attend. So then looking ahead to next week, we'll have episode 142, the 988 Crisis Jam, with mental health resources from Google and IASP. So we'll have Professor Rory O'Connor and Dr. Renee Schneider of Google on. Thank you all so much for joining us, and we'll see you next week. Oh, I'm sorry, and Beth Beckerson after that for CCPHCs. Thank you, guys.
Thanks, everybody.
Bye-bye.